Okay, so let me know when I have to start.
Yes, sir. You can start now.
So, hello everyone. My name is Mohammad Masseeb Umar. As you see, it is written, and a very happy World Glaucoma Week to all of you. So every year, second week of March, we celebrate as a World Glaucoma Week. And this World Glaucoma Week, as you all know, it basically has been celebrated everyone to create awareness about the glaucoma in the society. So I would be talking about basically pediatric glaucoma cases and what is pediatric glaucoma. The other speaker, Dr. Arihant, would be talking about the adult glaucoma or acquired glaucoma. So going further, so let me give you all of you a basic idea of the glaucoma. So glaucoma is normally like in a common sense. So glaucoma has been said as a disease. So commonly we know that it's a disease where the eye pressure increases. So normally glaucoma is a group of disease where you see basically a triad of problems. So first thing is that in a glaucoma patients, you will see intraocular pressure constantly rise, and mostly it is more than 22 mm of Hg. So if someone is having intraocular pressure more than 22 millimeter of mercury, so that comes under risk of glaucoma. And that increased pressure is, if that increased pressure is associated with optic nerve damage. So in this picture, as you can see, this is a two optic nerve, eyes optic nerve figure here. So figure in the left. So that is how a normal optic nerve looks. So here, the more brighter area that you are seeing, the yellowish area, that is called cup. And the area surrounding that is called disc. So what happened? This is how a normal cup and disc look. So this disc area should be, this cup area should be smaller than this disc area. So what happened because of the increased intraocular pressure? So there is a lot of retinal nerve fiber cells. So because of increased intraocular pressure, the nerve cells get damaged or they die. And because of that, you see there is an increase in the cup size, and we say it as a cupping. So here, what do you see in a glaucoma patient? Typically, how will you identify a glaucoma patient? By seeing a cup. So if you can compare this picture with that left one picture here, the cupping is increased, and you see the disc is very less. So this cupping is increased because the nerve fiber layer, the nerve cells that is there, that is dying because of the increased intraocular pressure. Sorry. And the third problem that is associated with glaucoma is the decreased peripheral vision. And that is one of the problematic area, or that's one of the problem that patient not able to identify, because the center, when you see in the center, it looks very good. The patient would be having very good vision, 6/6 vision, and the patient would not appreciate any problem in their vision. And what happening in that, because of this increase in intraocular pressure, and there is a changes or damage of nerve fiber cells, you see there is a decrease in our visual field. And this is very dangerous. If someone is having very small visual field, so that person is very prone for fall or prone for accidents. They would be having a lot of trouble in driving. Glaucoma also called as a snake of thief. So sometimes patient lost their vision, but they do not appreciate because they lost their vision. And this intraocular pressure, sometimes they are range of 22 to 30 millimeter of mercury, and they would not give any symptom to the patient. What happened? The patient come very late when their visual field is remaining very smaller. And this is one of the irreversible conditions. Whatever the visual field that has been lost, the patient cannot gain that. So that's why it is very important to create awareness. So just to review this, so in a glaucoma, you see basically there are three conditions that is associated with glaucoma. First is there is an increased eye pressure, like we have our body pressure, we see BP, say as a BP. Similarly, we have our eyes pressure, that is called intraocular pressure. Then you will see nerve damage and then peripheral vision loss. So since I am going to talk about the pediatric glaucoma, so let me tell all of you about like how this pediatric glaucoma is different from adult glaucoma. So this is an eye picture. I don't want to be very technical, but just to give an idea, right? So our eye maintain its pressure because of there is a liquid inside the eye that is called aqueous. That aqueous maintain the eye pressure. The eye need to maintain its normal pressure, that is between 10 to 20 mm of Hg. So how it maintains its pressure, there's a continuous aqueous that is flowing. If you can see this arrow that is showing the aqueous flow. So aqueous is produced by, there is a part in our eye called ciliary body. It is produced by the ciliary body. And from ciliary body, this aqueous comes into the anterior chamber, and from here, so there is a structure called trabecular meshwork. And note down this structure. This is a very important structure because we are going, I am taking again and again this name trabecular meshwork. So just make a note, this structure is a trabecular meshwork. So this area, like this aqueous, this is a liquid kind of thing, it is coming and it is flowing from this trabecular meshwork. So what happened in the glaucoma? Sometimes this trabecular meshwork, from where this flow is happening of the aqueous, that liquid, it get blocked. And because of that blockage, the aqueous is not properly coming out from the eyes, and that creating aqueous pressure inside the eyes. Okay, so it happens to, it is two kind of, one, you see there is an increase in intraocular pressure where the angle, so there is another structure that you all should know that is called angle. So here, if you can see, this is the iris and this is a cornea. This cornea and iris is making an angle here, an angle. So we say that glaucoma is an open angle and closed angle in the adult glaucoma. So just to give it a brief idea, like how the eye maintains its pressure and how eyes pressure increase. So eye pressure increase basically once the aqueous is not able to flow out from the eye. So so this is happening in the adult patient where trabecular meshwork is not working properly, and sometimes this angle get blocked. Now, what happened in the pediatric patient, in the congenital patients? So here you see there is a blockage of the angle. So there is a more development of the trabecular meshwork. So this again, I'm not going to detail of this structure, but the basic thing in the pediatric patient, there is the abnormal development of trabecular meshwork, and because of that, the aqueous is not able to flow out from the eye, and that causes increase in the pressure. So this is, I'm just skipping this picture. This is another picture. Just 1 minute. So, sorry for the interruption. Just 1 minute. I have to admit some. Can someone also work as a co-host so that they can admit all those people who are waiting in the waiting room?
Sir, but there was no options to make the co-host, so that's why.
Okay, fine. Okay, fine. So this is how. Okay, just I wanted to know one thing. That most of the participants are the students, optometry students.
Yes, sir. Optometrist, physiotherapy, as well as from nursing also.
Okay, so fine. So I will not go very much in detail of this structure. So this is okay. So this is how trabecular meshwork look in the eyes. So you see very fine structure that we see in the gonioscopic examination. That is very microscopic structure. But this whole intraocular pressure is like and this glaucoma is basically revolved around this trabecular measure. If it is not working properly, trabecular measure, so the eye pressure is going to increase, especially in the pediatric patients. Now, coming to the our main topic, like pediatric glaucoma. So what are the difference of glaucoma? So basically, we divide into two main types. One is called primary congenital glaucoma, and the second is the developmental glaucoma. So primary congenital glaucoma is one glaucoma where patient is having increased intraocular pressure. The child is having increased intraocular pressure without any other ocular or systemic abnormalities. The other eye parts are working totally fine. Even there is no abnormality in the body or any systemic abnormality, still there is an increase in the intraocular pressure. That is called primary congenital glaucoma, and sometimes it is also called as a trabecular dysgenesis. The second glaucoma that we see in the children are the developmental glaucoma. So developmental glaucoma is that one where the glaucoma. So just to again clear everyone, whenever I am saying glaucoma means, again, this is the three conditions that I have talked earlier. So the first and foremost thing in the glaucoma, you'll see the increased intraocular pressure. So most of the time I'm talking about the increased intraocular pressure. So in the developmental glaucoma, what you see in the children, there is an increase in the intraocular pressure of the child. But that increased intraocular pressure is associated with some other ocular abnormalities or some systemic abnormalities or some problem in the bodies, and because of that, eye pressure is increasing. That's why it is called developmental glaucoma. Glaucoma also has been categorized on the basis of the age of onset. So suppose, so normally we say congenital glaucoma, those glaucoma where the child is birthed with a glaucoma. So it suggests that child is having glaucoma even before the birth, which is in the mother womb. So that time only they have developed the glaucoma, and they are taking birth with the glaucoma. That glaucoma is called the congenital glaucoma on the basis of onset of the glaucoma, onset of the age. There is another type of pediatric glaucoma that is called infantile glaucoma. That is according to that glaucoma that we see, that is not immediately after birth, but any glaucoma that happens within 3 years of the age. So that is we called infantile. And any glaucoma that we see in the children after more than 3 years of age, that is called juvenile glaucoma. So why this classification is important? Because glaucoma management is depend according to this classification. So any glaucoma like congenital or infantile, any glaucoma less than 3 years of age, the primary, and any glaucoma where the child is more than 3 years of age, that's basically juvenile glaucoma. So there the first line of treatment is giving some eye drops or systemic medication, and the surgeons and the ophthalmologists try to manage that glaucoma first with the medicine, and then later on, maybe later year of their life, they will think of going for the surgery. So now I'm going to talk about the primary congenital glaucoma. I'm just giving you an overview. And why I'm just telling all those things, I will explain in last part of my slide, like how all of you can help screening this problem. So primary congenital glaucoma, as I said, this is that glaucoma that we see in the children. Those are basically born with the glaucoma. And these, as it is written here, it is a rare, but it is not as rare in India. So if you talk about the incidence, so the incidence of primary congenital glaucoma is 1 in 3,300 live births. And if you talk about the Western countries, it is very less. 1 in like 10,000 live births, you will see a case of congenital glaucoma, primary congenital glaucoma. So it is very common. It is also very common in the areas of the world where the consanguinity marriage is common, mainly in the Middle Eastern countries and India, basically in the southern part of the India, where the consanguinity in the marriage is very common. So where we see in this primary congenital glaucoma very commonly. And it is mostly 40 to 50% cases it has been seen genetically. And some cases and remaining half of the cases are sporadic. Means there is no family history, nothing. Still the child is born with the glaucoma. So it can happen anyways. Like it can be genetically or it can be sporadic also. And it manifested at birth, early childhood, and normally before 3 years of age. Also known genesis, goniodysogenesis, or primary infantile glaucoma. Earlier, it was also known by these three names, but now, according to the new ICD classification, it is known as only primary congenital glaucoma. And mostly, if you talk about the sex predominance, so most in male child it is seen more, and usually it is bilateral. So a child you'll see mostly in both eyes. I will talk about these symptoms or signs that you are seeing here more in my later slides. So once you have seen a patient, so now it's important for all of you or for all of us, like what is our basic purpose as an optometrist or as a nursing student or as a physiotherapist? The basic purpose that can we screen this patient so that we can refer those patients to an ophthalmologist where they can get proper treatment. So we can easily screen this patient because we don't need a very high-fi instruments to screen this patient because all the signs are the external signs and symptoms also. These are the, so in congenital glaucoma or pediatric glaucoma patient, there are three classical clinical triad symptoms. Those symptoms are the epiphora, photophobia, and blepharospasm. So the patient can have all the three symptoms or maybe any one or two symptoms from the three. Epiphora, commonly we say watering. There is a lot of watering that is called as epiphora. Photophobia, they are extreme. They are not a lot of glare problem. They are not able to open their eyes even in the room light. So if you they are having a lot of problem in their like normal room lights also, and they only open their eyes in a dark or very dim light conditions. So there's extreme photophobia, and the blepharospasm is closing their eyes very forcefully. So this is the typical clinical signs. These three clinical triad you will see in congenital glaucoma patients. Those were the symptoms. The signs, what are the signs we are going to see in these patients? So first one is that IOP is the main thing. IOP is intraocular pressure. So the eye pressure is always would be higher than 21 or 20 mm Hg. And normally it range between 30 to 40 mm Hg. The second sign that you're going to see is the corneal edema. So the eye that you are seeing is total bluish eye. So normally this cornea that we normally appear as a black. So normally cornea is a transparent structure. It appears black because of the iris color. So whatever the iris color, the cornea appears according to that color. But cornea is a transparent. But what happened in the congenital? Sorry, should I continue or?
Yes, sir. Yes, sir. You can continue.
Okay. So second sign that you will see in the corneal edema. So they typically appear as this corneal haze, you will bluish color because of the edema. And in clinical term, medical term, we say it is a eye drop. So that also you can very easily identify in a torchlight examination. The third one is the enlargement of the eye, or also known as a buphthalmos. Buphthalmos is bull-like eyes. So if you see this eye, the eye appears quite big. The eye appears big because of the large size of the cornea. That is also known as a megalocornea. So normally, if a child is less than 1 year of age, the normal corneal size or corneal diameter should be 10 to 10.5 mm. So if a child less than 1 year of age, and if you're seeing the corneal diameter is between more than 12 mm, so it is highly suggestive of the child is having congenital glaucoma. So this is again the second sign, and again this sign is very much identifiable with a torchlight examination. We don't need those high sophisticated instruments to visualize this thing. And this corneal diameter we can easily measure with the help of a scale. And the fourth sign is the Havis stripe, or fifth sign is the Havis stripe. I don't know how many of you appreciate this. If you see, there is a line, if you can see. So have a try, there is a layer in a cornea that is called a descemet membrane. So when there is a break in the descemet membrane, because of that break, so behind this cornea, there is aqueous humor. So when this descemet membrane get break, the aqueous get into the cornea and that causes corneal edema. So have this try, you'll see, and this is not possible to identify or visualize in torchlight examination. Normally we need to, it will be visible only with the help of a slit lamp, portable slit lamp, or maybe in operating microscope. And the last one is the scleral thinning. So you'll see a bluish sclera. So because of the high intraocular pressure, the sclera is stressed out, and that gives a bluish color. And also some, in some part, you will see bulging of sclera that is called anterior staphyloma. So these are the signs. So few of the signs are very easily identifiable, like cornea edema or corneal hydrops. And then cornea, large cornea size. Signs are easily identifiable. So that could be easily identified glaucoma patients. So there is two main part. One is the initial examination that can be done in when a child is coming to the clinic or in a OPD, or maybe you are going into a camp, and in a camp someone come with their child and you are doing the screening, their initial examination. And the second, the very important examination is the examination under anesthesia. Since these children are very small infants, mostly, most of the time they are less than 1 year of age. So they will not allow you to examine or perform the critical examination like slit lamp examination or measurement of intraocular pressure or measurement of refractive error in a normal condition. So they need an examination under anesthesia and to establish diagnosis, because there are another conditions also that mimic signs like pediatric glaucoma, but they are not pediatric glaucoma. So it's very important to establish diagnosis. So that patient is having pediatric glaucoma, so that proper treatment need to be started. So second step is very important. So what is our role? We can do the initial examination and we can screen this patient. We are not very sure, but we can screen that these patients are having these signs and they can possibly be a candidate of pediatric glaucoma, and we need to send them. Once we'll send them to an ophthalmologist specialized in pediatric glaucoma or glaucoma, so they will plan an examination under anesthesia where they will do all the examination and establish the diagnosis. So in the initial examination, basically we see the 3 clinical triad. That is basically, I talked in my earlier slide, that is photophobia, blepharospasm, TRE. So what is their degree? And you will see the external signs like corneal clouding, the picture that I already have shown you, this corneal clouding. In corneal assessment, this Harris trial we're not able to do in initial examination because we need a slit lamp and that portable slit lamp, and that we can only do in under anesthesia. So we would be needing measurement of this corneal, horizontal corneal diameter, so that we can easily do with the help of any scale. And any cornea diameter more than 10.5 mm or more than 11 mm in the child age 1 year should be suspect for a pediatric glaucoma. And if it is more than 12 mm, it is highly suggestive of pediatric glaucoma, and that child need to send for a proper assessment under an ophthalmologist specialized in the glaucoma. We need to do refraction, and mostly we get in refraction myopia. Why we need to do refraction? Because sometimes these patients, especially in the juvenile glaucoma, where the children is more than 3 years of age and they are having glaucoma, so in that cases, we are not doing surgical management, and the cornea is also clear. So we need to do refraction also because they are undergoing medical treatment. So we can't ignore this refraction, and here the optometrist role is very important. So why refraction? Because if there is any refractive error and we are not correcting that refractive error, we are only giving treatment for the glaucoma. So again, the child vision will be lost because they will end up with amblyopia. So again, this is very important we need to do. And the last one is the tonometry. And refraction we need to do with the strict retinoscopy. So you all should be very good with the strict retinoscopy, especially all the optometrist students who are listening this. So please learn the strict retinoscopy. It is indispensable tool. And tonometry. So tonometry mostly done under tonometry is basically the procedure to measure eye intraocular pressure. So we do this using by Parkin's tonometer. We do it in when the child is under sedation, under anesthesia, then we do this examination. Though there are now modern instruments, rebound tonometer called as, so those instruments can be used for measuring intraocular pressure in a very small children without anesthesia also. So as I already said, what you will see in the cornea examination. So you will see basically cornea diameter and the clouding. So don't only like assume that those eye which appears as a clouded, that is having only glaucoma. Because I said most of the time these glaucomas in the children are the bilateral. So here you see that both eyes cornea are enlarged. Both eyes are the ophthalmos, big eyes. This cornea is clouded, but this cornea is not clouded. That does not mean this cornea does not having glaucoma. So again, this figure B is the magnified picture of this clouded cornea. And this is again the same picture, picture of this child only. This is after treatment, after 3 months, like picture C is the 1 month post-operative. Once the child is operated for that, now the cornea gets clear because the pressure gets reduced and the cornea is clear. So here the Habit stripe that you see in this eye, that is normally not visible in the torchlight examination, but when you see in the slit lamp, you'll see this Habit stripe. There's a different grading of the cornea. Cornea clouding grading is very important because it tells about the prognosis. The cornea is very much clouded. The prognosis of getting vision is very poor. The child will not get very good vision after intervention of glaucoma. So earlier we diagnose them, earlier we screen them, and earlier we give them intervention, we can save their vision. So this is how the different grades. So see the grade 5 corneal edema, how dense it is. And as I said, there are developmental glaucoma also in the pediatric population. That is not because of the eye trabecular meshwork problem. It is because of the systemic abnormality. Like this child is having, if you carefully see the child face, there are a lot of pigmentations that is called nevus here and this part and this part. You can zoom in your mobiles, you will be able to appreciate this. So that is basically the clinical photograph of a child with a bilateral congenital glaucoma because of the vascular nevus on the face. So there are a lot of vascular nevus in the face. And if you see the child body also, there's a lot of vascular nevus all over the child body. And because of this increased pigmentation also, there is a glaucoma in the, because the trabecular meshwork is not working properly and the eye pressure get increased. And then there is another condition called hemangioma. And because of the hemangioma also, this glaucoma can happen. And iridia is another condition where there is the absence of iris in the eye, and that also can cause glaucoma. So all those glaucoma that is because of the systemic or other eye problem is called developmental glaucoma, and this is some of the examples of that problem. So basically how we manage those patients. So the basic aim of management is irrespective of whether it is an adult glaucoma or a pediatric glaucoma, the basic aim is to decrease the intraocular pressure. It is very important because when there's increased pressure, this is the optic nerve. It directly damages the optic nerve, and there is a lot of nerve cells in the optic nerve. And we all know once the nerve cells get damaged, they are not going to regenerate. So that's why it is irreversible. And that's why the blindness caused by the glaucoma is the irreversible blindness. So very important to decrease the pressure. This is always the first step. So decrease the pressure, and there is a different modality to decrease the pressure. We can go for the surgery. We can go for the different kind of drops and systemic medication. It depends on the a treating surgeon, ophthalmologist, they will decide like what is best thing to do with the child. And once we manage to control the IOP, then also always correct refractive error, because these are the children, and if they are having the refractive error, and that they most of the time they have, and if you're not treating that, they will end up in amblyopia. So we need to manage that also. So normal general treatment. So general treatment for any congenital glaucoma is the surgery. In the surgery, basically we do goniotomy or trap with trap. I'm not going in detail into this, but this is the surgical process that is normally done to decrease the pressure in the children's. So to conclude my presentation, once the pediatric glaucoma has been thought as a condition which is not treatable. So if a child is born with a congenital glaucoma, they are not treatable and they are going to be blind. We can't do anything. But now in the modern scenario with the very sophisticated machines that we have and technology, the pediatric glaucoma has become reasonably manageable in most of cases, and the children get good vision and good throughout their life. So the key is the early and accurate diagnosis of congenital or pediatric glaucoma before irreversible damage of the optic nerve takes place, because the more delay they will do, the more damage it will cause to the optic nerve. And the damage that already has been done to the optic nerve, it is not going to be reversed. So very important to early diagnosis or early screening. And we all can do, like, irrespective of whether you are optometrist, you are physiotherapist or nursing student, or you are a medical professional, or you are a general person. If you are able to identify these basic signs, we can easily screen this patient and send them to an ophthalmologist for proper management. So to end, I just wanted to share this child photo. That again, the source, all my picture source I have taken from one of the articles from the Indian Journal of Ophthalmology. So you can go and read this very wonderful article. A lot of case-based studies or case-based scenarios are there. You can learn more from them. So this is the child who is operated for primary congenital glaucoma at the age of 1 week. So these children can be operated at the age of, I know in my previous organization, we have operated, surgeon has operated a child only 3 days of, 3-day age. Then that child has been operated for glaucoma, because early intervention is very important. So this child has been operated at the age of 1 week for the pediatric glaucoma, and now the same child, 3 years of age, and it's doing wonderful. Suppose the same child has to blind, and they have to remain with their blindness throughout their life. So let me thank you, everyone. Thank you especially to ITM, Minnie ma'am, and Matthew for giving me this opportunity and sharing. Again, this opportunity